Should we get started? So OTEP calendar has respiratory emergencies this month, so we're going to go over kind of a variety of respiratory emergency topics. I'm going to stay away from intubation and airway management and more focus on the disease processes that may end up culminating in intubation. We'll touch on it briefly, just some pearls at the very end for what to keep in mind when we intubate, but I'd like to try and continue to keep our airway management lectures into a series that we can build off of as we move, or as we try and move towards a formal airway curriculum, right? So starting with basic airway management, moving into the adjunct airways, CPAP, and intubation, to try and keep those things in a nice kind of contained multi-series didactic with psychomotor component. So I'm not going to touch on a lot of that today. We'll briefly hit on it. Mostly today I want to talk about the disease processes that culminate in respiratory failure, right? So you guys have heard the term blue bluffers or blue bloaters and pink puffers, right? Talking about COPD and emphysema, essentially. So your pink puffers and your blue bloaters is kind of a classic little description of respiratory emergency. So we're going to go, I think it's important, we've touched on this before and you will see this again. There are a number of slides that we're going to start things out with that are a review of anatomy, physiology of ventilation and perfusion and oxygenation, because I think it is critically important when we approach these patients you understand the mechanics that take place, right? And to understand intimately what negative pressure versus positive pressure ventilation is and how we can dramatically affect people's physiology by converting them from one to another, okay? And it makes sense on how we manage everything from a flail chest to an open sucking chest wound to an asthmatic to a COPDer to any number of airway thoracic emergencies. That concept of negative pressure, positive pressure, and what our impact is when we switch from one to the other, you've got to understand that intimately. So these are going to be slides that you're going to see over and over and over and over again. And finally, when you're like, dude, we've seen this 50 times, 60 times, I get it. Then I'll stop putting them in there, okay? But until then, it's going to be part of every respiratory lecture because I think it's critically important to understand how it makes it, what it does, okay? We'll talk about our obstructive lung diseases. COPD and asthma are our predominant obstructive lung disease. We talk about COPD. COPD is two things that get lumped together, chronic bronchitis and emphysema. So we'll talk about chronic bronchitis, emphysema, asthma, and then we're going to talk about their management. Asthma management is a little bit difficult, okay? You can't quite say it's exactly like emphysema or exactly like COPD, particularly when it becomes the more severe cases, status asthmaticus, so we'll talk a little bit about that. We'll talk about pulmonary edema pathology and management. The difference here is that this is cardiac etiology lung disease. This is pulmonary etiology lung disease, right? So this is lung disease is a manifestation of heart failure. We'll talk about that. And then we're going to touch on CPAP, a little bit about intubation, and then tracheostomy complications, because we never get a chance to touch on that. It's in OTEP. We have a young kid coming home from Seattle who's got a trach, and parents were concerned about stoma management, and I just want to take this opportunity with this new kid in town and that request from that family that we'll address it here today also, okay? And essentially what to look for with complications, how to replace them, and some of the dangerous things that can happen with stomas. So, questions? All right, good. So, ventilation physiology. This is the physiology of ventilation, just how do I get the air from the environment into my lungs where it can take place in gas exchange, right? It's the conduit, right? How do I get air from the environment, which is predominantly nitrogen, remember, like 70 what percent nitrogen? 70 something, 78, and then we got 21% oxygen, and then we got a little bit of this and a little bit of that mixed in there, right? Room like this will probably have a little more methane at the end if we're not careful, but very small proportion, right? So predominantly nitrogen, some oxygen, we pull that in, we take the oxygen, right? We suck it across on the hemoglobin. How do I get that air into my lungs is what ventilation physiology is, right? It consists of a single inspiratory, expiratory cycle or exchange, okay? This is created by a vacuum, right? So I have a mechanical movement that creates a suction gradient, right? A negative pressure to positive pressure gradient, and I move air from an environment where I am positive pressure into my chest, which is negative pressure, okay? Or into my thoracic cage, which is negative pressure, okay? And then, so that's the active component, which is predominantly a skeletal muscle activity, right? The diaphragm contracts, flattens out. I use my accessory muscles. I make a bigger chest cage. It's just like a bellows with your fire. You know, you got your little bellows bag, right? And then passively I recoil for expiration, okay? So the mechanics is in the creating a bigger volume. I got to fill that volume so it creates a vacuum. I suck air in and I passively exhale, okay? I can forcefully exhale if I need to, and you'll see that with bad asthmatics. We'll talk about that a little bit later on from trapping. But generally it's a passive motion when it is when it's done in normal physiology, right? So I create a big wall, I create a bigger volume here, diaphragm flattens out, it contracts and flattens, the chest wall gets enlarged, I create a negative vacuum space in the lungs and it pulls air in, okay? It sucks air into this space. This pleural space here is what we call a potential space, right? So if I take a garbage bag or a plastic bag and I have a bucket of water and I dunk that bag in a bucket of water, you do this whenever you get your chicken or your steak and you're making your little marinade and you fill up the sink and you want to make sure that all the surfaces of the meat get marinade on it, right? So you just stick it in the sink and force all the air out, right? And you zip it up. Well, where those bags touch each other, that's a potential space, right? I can fill that space with something, right? But as long as there is a seal there, when I pull one side, I'm going to stick to it, right? It's a negative pressure vacuum, so it holds that pleural surface against the chest wall. It's a potential space. Now I can fill it with air, and that gives me a pneumothorax, right? I can fill it with fluid, and that gives me a pleural effusion. I can fill it with blood, and that gives me a hemothorax. So multiple pathologic conditions exist where I fill that potential space and into something where I then compromise the ability for lung expansion, right? Does that make sense? So when we talk about ventilation physiology, how we kind of characterize or describe these volumes is on what's called a spirogram, okay? Or spirograph. I think that's what it's called. I'm pretty sure. Yeah, spirogram. So typically in a normal tidal volume, which is what? Like what you're doing right now is tidal volume breathing. That's what you do when you are just sitting around doing not a whole lot of much, right? So you don't require a lot of extra volume. So our typical standard respiratory volumes are tidal volumes, okay? So most of that is going to be made up of alveolar air, which takes place in gas exchange. So if I have 500 cc's, right? Tidal volume is generally about 500 cc's, right? About, what, 350 or so is actually alveolar gas, alveolar exchange, right? So this is the proportion that can participate in gas exchange, okay? And then I have a little bit of loss to what we call physiologic dead space, and more loss to anatomic dead space. And essentially, dead space refers to anything that is not participating in gas exchange, okay? So if I look at air within the trachea and the bronchioles and the bronchi, well, that's air that's in that space that's not participating in gas exchange. That is anatomic dead space, okay? Physiologic dead space would be any area where I have air in the alveoli, but it's just not participating in gas exchange. So an underperfused segment, or an area that has some fluid in there, or collapsed alveoli, and I'm just not getting good exchange in that area, okay? So certain disease conditions can actually increase my physiologic dead space, right? So if I got bad CHF, bad pneumonia, and I essentially take out a large portion of functional alveoli, I can put gas in there, but I won't get good exchange, right? Or like with a pulmonary embolus, I send a big blood clot to a big portion of my lungs, and I can get air into that space, but I can't get blood there to participate in gas exchange. So that becomes physiologic dead space. Physiologic dead space. That makes sense? Right? So this, depending on our disease state, these proportions can potentially change. But in general, normal tidal volume breathing is about this makeup in terms of lung volumes, okay? So tidal volume breathing, as you can see here on this spirogram, makes up a very small proportion of total lung volume, right? We underutilize the vast majority of our lungs, right? There is a lot of reserve there. So think about things like when we say with our OSI protocol, right? We put you on maximum flow, non-rebreather mask in an effort to replace nitrogen in your lungs with oxygen, right? So we're denitrogenating your lungs. You can say pre-oxygenating, but really what we're trying to do is denitrogenate your lung. I want all of the air that's in there to be oxygen air. I don't want it to be representative of what's in the environment. I want it to be like two big oxygen tanks, right? So I'm going to take out all the nitrogen, and I'm going to fill these oxygen tanks. And that gives me safe apnea, right? So I can do that, I can achieve that by tidal volume breathing for how many minutes? How many minutes? 3 minutes, right? 3 minutes of tidal volume breathing with full face mask, you can exchange out almost all of that nitrogen, right? Let's say I don't got 3 minutes. I want to get this done and started within the next 30 seconds. Then I can say what? 8 tidal volume breaths, right? So what's a tidal volume breath? A vital capacity breath. 8 vital capacity breaths. What is that? Vital capacity is essentially everything that you can blow out and suck in. So if I empty my lungs all the way, so do it. Everybody do it. Blow out all the air that you have in your lungs until you have no more air that can come out. Okay? Do it. Blow it all out. All the way out. All the way out. You can't get any more out, right? And now, suck in as much air as you can possibly get in. Okay? That's vital capacity. That is utilizing the amount of lung that I can possibly utilize under my own physiologic state, right? So as a young, healthy, vigorous male, right? I can get probably 4 liters, okay? Right? Now, if I have certain lung conditions, I can't do that. Let's say I have restrictive lung disease. I'm scarred up. I worked in the mines for a long time. I've got scarring on my lungs. Then my total lung volume or capacity, or my vital capacity, is going to shrink because I'm scarred. I can't expand. My sponge is stiff, so I can't get that big. So sometimes disease states are going to restrict that. If I have a big pleural effusion, I can't expand that lung because I've got a big fluid collection in that potential space, that pleural space. So I can't get that volume, right? So certain disease states will interfere with this, but generally 8 vital capacity breaths is enough to fully exchange the gas that you have in your lungs at any one time, okay? Does that make sense? There's some lung residual volume that I have the capacity to use it, but I'm still underutilizing, right? And sometimes this is where we see the benefit of ventilating people, right? A lot of this is atelectasis, where I just can't fill that lung by negative pressure mechanics, right? And I get converted over to positive pressure ventilation, and now I can recruit a lot of this lung tissue that otherwise I'm just not maximally filling, okay? When I get into volumes down here, though, what do I got to worry about? What do I got to worry about? Let's say I convert somebody over and I intubate them. Negative pressure ventilation, positive pressure ventilation. Now I'm using almost all of their lung volume, right? Barotrauma, right? So this is where I start to get into the danger zone of barotrauma, okay? So we got to talk about that. And when we talk about asthma, particularly in asthma, you'll get a condition called air trapping, where I breathe in, but I can't get all my air out. And when I start to stack breaths, right? So I breathe in, I can't get it all out, right? And then I breathe in again, and I can't get it all out. And I breathe in again, and I can't. You start to stack air and trap it, right? So traditionally, you get an x-ray on people with obstructive lung disease where they can't fully expire, and they have large lung volumes. They'll be overinflated. And they kind of live, even though they're not totally functional, they're kind of living down in this big volume range. And so you've got to be careful about barotrauma in those folks, okay? So when we look at on a waveform capnograph, so we obviously, this is not what we're seeing, this inspiratory, expiratory cycle. This is just volumes, right? This is just purely gas volumes. When we look at capnography, I'm really only measuring the exhaled CO2, right? That's it. There's not a lot of CO2 in the environment. There's a lot of CO2 in my lungs, right? There's a disproportionate amount of CO2 in my lungs. So when I breathe it out, I emit it, but this is a much bigger volume than my lungs, right? So I can measure that as that expiratory volume. And this gives us probably the best picture objectively of ventilatory physiology of all the tools that we have in the field, okay? So generally, AB, this little section from A to B right here, right, is exhalation of the dead space. So it's that initial little bump up right here. It's that initial little step. So I'm moving out air that didn't participate in gas exchange, right? So it still represents what's in the environment, okay? So when I move air from my trachea out into the environment, it looks a hell of a lot like the air that's in the environment because it didn't participate in gas exchange. I didn't suck oxygen out of it, and I didn't offload CO2 into it, right? So I don't get a whole lot of change in this picture. But then as I expire more and I start to see alveolar gas, right? Alveolar gases start to participate, and I bring up this level from 0 to now, in this circumstance, 40 millimeters of mercury, okay, which is my measurement of CO2, okay? So exhalation is this phase right here, up and out, and then inhalation, I'm dropping back down because that sensor now is sucking in predominantly nitrogen and oxygen, right? So now that concentration drops dramatically, okay? Notice how quickly it takes to suck that in, right? So I suck this in, drop it down to 0, out to A is the end of that cycle. Now I'm going to expire, right? And that comes back up, okay? Make sense? So we're looking at expiration, inspiration. Expiration, inspiration, okay? In general, I'm going to have a rapid inspiratory phase and a slightly slower expiratory phase, okay? The mechanics of ventilation, this takes about 1/3 of the time. Normal exhalation takes about twice that long. So when I break this into thirds, 1/3 is inspiration, expiration is 2/3, okay? So the longer period is on the exhalation phase. Normal is about 1 to 2, right? So 1 part exhalation or inspiration, 2 parts expiration. One of the things that we can do, and you should characterize in terms of your physical exam, and you should mention in people with bad lung disease, is what's the impact of their pathologic state on this ratio, okay? So have you ever heard someone say they have a prolonged expiratory phase, right? That is as good as exam finding as hearing wheezing on somebody's exam. And sometimes even better. If I've got such bad asthma or such bad COPD that I can't even move volumes, you may not hear anything, but you will notice a significant difference in inspiratory to expiratory ratio. And what that tells me is that it takes a long time to get that air out, right? So you tell the COPD, say, take in a deep breath and blow it out as fast as you can. For you, I'm going to have you, you're going to do this too, right? Take in a deep breath, blow it out as fast as you can, right? Deep breath in, blow out as fast as you can. You ask an asthmatic or a COPD to do that, and what do? They go. It takes them a long time to get that air out, okay? And that is a pathologic finding of obstructive lung disease. So understanding that ratio can help you, essentially can help you identify people who are probably obstructive. Or if you got somebody you're like, listen, I don't hear anything. I know sometimes terrible asthmatics don't move any air at all. She's saying she's having a bad asthma attack. I'm listening to her lungs. I don't hear wheezing. Taking a deep breath, blow it out as hard as you can. And she goes, whew. Is that asthma? No, that's not an asthmatic attack, right? She goes, yeah, you probably should treat that person like an asthmatic, okay? Does that make sense? Incorporate this slide into your physical exam, okay? Most of you probably do not incorporate this into your physical exam. It should be a part of your respiratory exam. Inspiratory-expiratory ratio. Normal inspiratory to expiratory ratio or a prolonged expiratory phase, okay? Document it. So, in terms of pathologic conditions, we talked about putting things into that pleural space, that potential space. That can create pathological conditions. But disease of the airway and the alveoli themselves produce pretty much 2 types of lung disease. Restrictive lung disease and obstructive lung disease. Restrictive lung disease is anything where I have stiff lungs, scarred, stiff lungs that they don't want to expand, okay? and I'll have low lung volumes, I'll have a lot of scarring, and it'll be difficult to oxygenate those people, okay? Then I have obstructive lung disease. And obstructive lung disease can be a disease of the airways, or it can be a disease of the alveoli, okay? When it's a disease of the airway, it's related to airway resistance. So bronchospasm, right? You take those medium-sized airways that have smooth muscle associated with them, designed so that I can dilate or contract depending on what I need, right? When a bear chases me in the woods, I get epinephrine in me and I dilate out my bronchioles and I breathe better and faster and I run faster and I oxygenate better. And that gave me just that little edge over the bear and I got away, right? But if I couldn't do that, I'd get eaten, okay? So it's part of that fight or flight response, okay? Now, when I have a disease of that response, I get bronchospasm. I get irritable, right? I get irritability and I spasm down. That's what happens with your asthmatics. They get irritability, they spasm down, okay? So I decrease the diameter, I increase the resistance. We see this in chronic bronchitis, bad smokers, but it's primarily because the fact that they put pollutants into their airways every day, over and over again, and they get thick, irritable, boggy airways because they're not designed to be filled with smoke all the time, right? They're designed to breathe good, clean, fresh air. And when I put smoke and irritant in there, they get boggy, they get mucousy, they get thick, they have a lot of secretions, and I end up with tighter diameter airways, and I have a hard time getting air out, okay? So I have obstruction, or I have resistance to airflow because I'm putting that air through a tighter pipe, okay? And then lung compliance, the opposite of pulmonary fibrosis, is emphysema, where this sponge is so broken up and old that my alveoli, what should be a nice cluster of grapes, is now kind of like a, I don't know, it's like a grapefruit, right? I mean, the surface area, they've all collapsed, they've fallen apart, they're friable, and so instead of having lots of little bubbles, little air pockets, I now have big air pockets, right? So less surface area for gas exchange, for one, but also areas to trap air. Areas where I just kind of hold on to air that doesn't participate because I got this big volume and it's stuck in there. And then when I want to blow things out, they just kind of collapse and fall on each other and then block the outlet, okay? Does that make sense? So that's the pathology behind our major airway diseases, okay? Does that make sense? We talked the other airway diseases we talked about, pulmonary edema and pneumonia, are predominantly diseases of increasing my physiologic dead space, right? Or interfering with gas exchange itself by compromising the integrity of that alveolar to capillary membrane, okay? So that's how we classify these pathologic processes. Does that make sense? So gas exchange obviously takes place in these nice clustered alveoli, right? Lots of them, a huge amount of surface area, right? Massive amount of surface area, and all very intimately associated with the capillary network. And that's where my gas exchange takes place. So I breathe in, here's all that anatomical dead space, right? All these airways are my anatomical dead space. These are the areas, these medium-sized airways, these bronchioles are the location where I can have bronchospasm or mucus production and give me COPD, asthma. Broken apart alveoli give me emphysema. Fluid-filled alveoli or pulmonary edema or pneumonia, right? So when we look at that interface, here's that alveolar membrane. Here's that capillary membrane. I have a strong affinity for oxygen in my hemoglobin, right? That hemoglobin molecule has a very strong affinity for oxygen and sucks it across. I have a low oxygen environment in the bloodstream here, so I move across the gradient and I quickly pick up that oxygen with hemoglobin. and that becomes my oxygen transporter, right? I have a high concentration of CO2 and water after metabolism, after aerobic metabolism. Here's my byproduct that's carried back from the cells and the tissue. And since I have low CO2 on this side and high CO2 on this side, CO2 goes down the gradient, and I offload CO2, and I pick up oxygen, okay? So pulmonary edema, if I put a layer of fluid right here, I interfere with my ability to get good gas exchange, right? If I put a layer of pus here and dead white cells and bacteria, then I interfere in inflammation, then I interfere with my ability to create gas exchange right here, right? If I throw a clot to my lungs and I have a pulmonary embolus, well, I block all the blood flow on this side so I can get the gas in, but I can't get the blood in, and I lose that opportunity for gas exchange, okay? Make sense? So how are we going to measure this? We measure this primarily on our oxygen saturation probe, right? So what is the oxygen saturation probe measuring? Hemoglobin saturation, right? It's not measuring the amount of oxygen that's in your blood. It's measuring the amount of hemoglobin that is bound with oxygen, okay? Does that make sense? So you give me high flow O2 for 45 minutes, right? I'm going to be 100% SpO2, right? I'll be fully saturated. But I'm going to have a shitload of extra oxygen in my blood. And the way I measure that is with a PaO2, okay? That gives me the arterial measurement of oxygen in my blood. So I'll have a bunch of unbound, free oxygen in the blood. It just so happens that you can just about maximally load all your hemoglobin with 21% oxygen. Right? What a freaking coincidence that would be, that I can maximize oxygen utilization with ambient air, right? Okay? So there's just so happens to be enough oxygen that I'll saturate what needs to be saturated without a bunch of extra oxygen, right? And I'll fully load all my hemoglobin. So I'll load them up. There will be no leftovers, and I can do that on 21%, right? We are designed for this environment, okay? This is where we live. Now, sometimes when things aren't working the way they need to, right, or I go places that I'm not made to be in, right? I'm going to go climb some mountain somewhere, right? Not here. Not where I belong, okay? What happens when I go to higher elevations? I have lower oxygen concentration, right? So I'm doing my damnedest, but man, I just can't quite pull it off. And you look at the SpO2 of people in that environment, and they are not loading their hemoglobin, right? They're living in the 80s, right? So at base camp for Everest, people sit there because their body has to equilibrate or get used to that environment. And generally, the way I do that is I create more red blood cells. So I'm just going to create more boxcars or transport agents for carrying oxygen. So I'll pick up more oxygen. I'll be able to utilize more by increasing my hemoglobin levels, okay? So I won't saturate all of them, but I'll get more of them, okay? Now, if I belong there and I'm a Sherpa, well, I'm made to be in that environment. And they've adapted for that environment, and they function because they have a different physiologic makeup in terms of hemoglobin concentration, red blood cell concentration, right? So their bodies have adapted to that environment. You bring him down here, or let's say I go train for the Olympics in Denver, because Denver's high elevation. So I'm going to have my Olympic training place there. You essentially are like a legal blood doper, right? That's what you're doing. Your body's creating more red blood cells. You're blood doping, right? It's like going and getting a pint of blood before you run the race. Like, never felt better, right? If you train, you go get that pint of blood by training there for several months in advance, and you run your marathon in San Francisco, and you're like, psh, you guys got nothing on me, right? So essentially all you're doing is manipulating this process here, okay? So FiO2 versus PaO2. We're going to talk about this for just a sec, right? So FiO2 is the fraction of oxygen in the inspired air. So right now, 21%, right? When I start adding a face mask or liters or whatever, then I effectively change the FiO2. If I get you on a closed circuit, we talk about a closed circuit, that is 100%, or that is a purely closed circuit from my alveoli and my airways to a respiratory source or to a gas source. So if I'm ventilated, intubated and ventilated, that is a closed circuit, right? I am only getting what is delivered through that ET tube. And I can control that with 100% oxygen if I hook that source up to 100% oxygen, or I can manipulate that to be wherever I want, right? That's a closed circuit. I cannot get a closed circuit with face masks, right? You've seen in the OR they have that one that looks like a floppy. You've seen the mask they use in the OR. It's real floppy on the edges. There's not. It just kind of like drapes over the face. It's like a big rubber kind of a, and it flops on there. That's about as good as you can get. Just flops down and makes a seal, okay? And they ventilate through that, or they use gas through that mask. But what we have, the closest we can get to maximally affecting this is by the highest regulator flow with a non-rebreather mask, and we can approach the 90s, but we can never really get FiO2 of 100%. We say 100% FiO2 or 100% face mask, but we really can't achieve that because it's not a closed circuit, right? PaO2 is the amount of oxygen dissolved in the blood, right? So if I put you on that, I'm going to create a very high PaO2. Normally, I want this to be, 90 or so. But if I put you on a non-rebreather mask forever, it's going to be 320, 250. That's a lot of unutilized oxygen, which can create oxidative damage, right? Now, FiO2 can influence a PaO2, and we just talked about that. By increasing how much I breathe in, I'm going to dissolve more. Doesn't mean I'm necessarily going to change my SpO2. Doesn't mean I'm going to change the hemoglobin saturation, right? But I'm going to definitely change the amount of available oxygen in the blood. And then a lot of our diseases are related to shunt physiology. So a mismatch of lung tissue to blood flow. So pulmonary embolus is a shunt where I have no blood but okay gas exchange, right? I can also get a shunt from good blood but lousy alveoli, right? So they miss their opportunity to exchange gas. That's a shunt, okay? So when I add a nasal cannula up to about 6 liters, I'm adding 3 to 4% per liter. So if I give you 1 liter, your FiO2 is about 24 to 25. If I give you 2 liters, you're about 25 to 26% FiO2, okay? Once I put you on a simple mask at 5 to 10 liters, I can get you between 35 and 55 FiO2. And then a non-rebreather mask greater than 15 liters puts me about 60 to 70. And then maximum flow regulator, which for us is about 25, only gets me to around 90. That's the best we can do, okay? Just there's too much opportunity to mix ambient air in there because it's not a closed circuit. Okay. So that's our review of ventilation, oxygenation, physiology, okay, with a little touch of pathologic conditions in there. So let's dive a little bit deeper into the pathologic states, okay? So COPD, chronic obstructive lung disease. Technically, asthma really shouldn't be a part of COPD, but there's a lot of crossover in how it presents, okay? Predominantly, it's emphysema and chronic bronchitis, but you can look at these disease processes in a very similar group of what we call the obstructive lung diseases, okay? So in a normal bronchiole, I have this nice, clean, open, patent conduit for air exchange, right? In COPD, I have edematous. A lot of times I have mucus production, right? I have bronchospasm, and so I have a smaller conduit, thereby increasing airway resistance, okay? Additionally, with emphysema, you can see how I lost that nice clustered effect here. I lose the integrity of those alveoli, and they end up collapsing and becoming very fragile, okay? So this is the diseased state. This is the normal state. I know it's a little bit blurry. So clearly, some of America's finest have succumbed to the temptations of tobacco use. The truth of the matter is, COPD and emphysema are smokers' diseases, okay? Asthma, you just kind of got born with. You're probably a little bit atopic is what we call it, right? Probably more prone to allergies, things like that, and that's more of a genetic thing or sometimes can be or is affected by environment, but predominantly that's just how you are. You're born that way, okay? But smoking is the cause of COPD and emphysema, by and large, the vast majority, right? So when someone says, I have asthma, and I say, are you a smoker? And they say yes, then either they're a dumb asthmatic, for one, right? But they're probably more COPD than asthma, okay? I don't know if you agree with that or not. But smoking is the cause of emphysema and chronic bronchitis, okay? Now, asthmatics, they can, unfortunately, anything can trigger them. They have this very irritable airway, right? It's irritable, it's edematous, and edematous tissue wants to spasm, okay? And whatever your trigger happens to be, right? Whatever your trigger happens to be is what's going to trigger an asthma attack, okay? So mold, pet dander, dust mites, viral syndrome, strong smells or chemicals. Some people have exercise-induced asthma. Obviously, smoke is a pollutant and an irritant. Weather changes, cockroaches, pollen, anything can be a trigger for asthmatics. And a lot of managing their disease is just avoiding triggers, right? Just avoiding triggers and using anti-inflammatories, which are generally going to be inhaled steroids, okay, depending on the level of severity. And that helps with keeping that edema under control, okay? The treatment for chronic bronchitis and emphysema is to just stop smoking, right? But most don't do that. And ultimately, you can end up with permanent damage, and it doesn't matter if you stop smoking or not, you're screwed, right? But early on, the best treatment is the avoidance of tobacco, the inciting event, okay? So here's a nice, beautiful, non-edematous, open, patent bronchiole. Here is an asthmatic bronchiole that is edematous, lots of mucus-producing cells, plug the airway, the same physiology here, or the same pathology in COPD, chronic bronchitis. And then I get these areas of bronchospasm related to this irritability. So when we treat this, we treat it two ways. We treat it by reducing the inflammation and reducing bronchospasm, okay? So albuterol reduces bronchospasm, but our use of steroids, ipratropium, which actually has a little bit of bronchodilatory effect, but does a lot to dry up these secretions as well because it's an anticholinergic, right? So we kind of hit it from both sides, inflammatory and bronchospasm, okay? So air trapping is a phenomenon that I think we have to be aware of, right? When we talk about stacking breaths for people, okay? So what happens is when I move air in, I really don't have a difficult time pulling air in because what am I doing? Negative pressure ventilation means I'm sucking things in, right? I'm sucking things in, I'm creating a vacuum, and then I'm passively exhalation, right? So when I'm sucking things in, I'm creating a pull, right? Well, I can also pull some of this area so I can actually get air in relatively easily, but then when I go to blow air out, I increase my interthoracic pressure and I collapse those airways. And so I end up trapping air in the alveoli, okay? So when I look at a respiratory cycle, here's flow, right? So inspiration and then expiration. Normal expiration should be 2-to-1 process, right? Or a 1-to-2 process. And I slowly expire that air out. But if I don't expire all that air out and then I add my next breath, see what happens to that volume is that I now add a little bit of air in there, okay? Does that make sense? You get air trap. And then this is what puts me at risk for barotrauma, okay? What does that look like on waveform capnography? Well, here's our normal inspiratory-expiratory ratio. Well, here's what it looks like in someone with obstructive lung disease. So I'm air trapping, so I'm accumulating CO2, right? I'm accumulating CO2 because I'm not offloading it. So my concentrations are higher in my alveoli than they should be, right? Which consequently makes it harder to offload from the bloodstream. So it kind of backs up all the way through. If you think about you dam a river, right, then I'm going to kind of back up water behind it. Well, first I'm going to back up CO2 into the alveoli because I can't offload it. But eventually I'm having less and less of a gradient from CO2 levels in the blood to CO2 levels in the alveoli. So I have less drive to move that CO2 across that membrane, right? Because it wants to go down a gradient. It wants to go from a high concentration to a low concentration. And it's a steep slope when I got a low concentration in the alveoli and a high concentration in the blood. It's easy to go down that slope, right? I'm going to offload that CO2 very easily. But as I start to accumulate CO2 in my alveoli, right, I'm not offloading. I have a smaller slope, less of a gradient. So I then back up CO2 into the bloodstream, right? And that's where I end up with people with respiratory acidosis, right? I'm holding on to that CO2, which essentially is going to interfere with my ability to maintain an appropriate pH, okay? So that's how you end up with respiratory acidosis, is I can't offload that CO2, right? So naturally, my CO2 levels are higher when I measure what is coming out. They're higher, right? So in this case, what, 45, 50, 60, 65 is my peak as opposed to 40. So my shark fin appearance is going to be taller. That end-tidal CO2 number is going to be higher. And when I blow out my air, instead of getting that nice rapid phase, what I end up with is this shark fin, slow arch expiration where it's hard to get all that stuff out, right? There's not a clear takeoff between alveol or physiologic dead space and alveoli. There's just kind of this really slow pore exchange shark fin appearance, okay? And you can see this change as you give people treatment, right? So you show up on scene and you put someone on end-tidal CO2 and an asthmatic or a COPD patient, and you put them on end-tidal CO2, and then you start to treat with bronchodilators. 20 minutes later, if you take those two side by side, you'll see an improvement if they have clinical improvement, they're more than likely you're going to see an improvement or a change or a transition from what was this pattern to more of this pattern, okay? So how do we describe asthma severity? Well, if you're intermittent, it happens a couple days out of the week and a couple nights out of the month, right? You use your rescue inhaler. If you're mild persistent, then it's greater than 3 times a day, but less than 1 episode a day, or greater than 3 days out of the week, but less than 1 episode a day, 3 to 4 nocturnal awakenings in a month. You had to take oral steroids more than twice in a year. So you can see how these it's essentially symptom-based, both day and night. And then ultimately, if you're a severe persistent asthmatic, then my symptoms happen all through the day. I wake up every night, and I'm using my rescue inhaler multiple times a day, right? And people can kind of fluctuate their asthma, how well they control it. They can kind of fluctuate. If you say, what kind of asthmatic are you? Are you moderate persistent? They're going to be like, I'm just an asthmatic, man, and I'm having a hard time breathing, right? But when you look at pulmonology notes and you communicate with pulmonologists, so I want to know how bad an asthmatic is, this gives me, sometimes I can reference their notes, this gives me a sense of what's this person's baseline, okay? And I could be a mild persistent asthmatic until I end up with a viral infection, and now I fall into a more severe persistent asthmatic until I get over that course of acute inflammation or acute trigger till I get back to where my baseline is at, okay? So severe status asthmaticus is terrible bronchospasm and respiratory failure despite bronchodilator therapy. They're going to be hypoxic and hypercarbic, okay? Remember, they're going to accumulate CO2, so they're going to have hypercarbia plus hypoxia. Most are triggered to viral URIs as a trigger. So someone who's a baseline asthmatic who gets a bronchitis, that extra insult to the bronchi is what causes a severe bronchospasm. And in these folks, parenteral steroids and epinephrine are indicated. Okay, so for you guys, you don't have steroids, but this is who we're giving IM epinephrine to in the field. Okay, who just brought me a really bad asthmatic the other day? I think it was Valley guys. Brought me a really bad asthmatic. They tubed him in the field. You Valley guys were on that? I think it was Reese. Anywho, good case. Yeah, we'll talk about ketamine. They didn't give him ketamine, but I think it's because the IVs weren't in the right spot. But he did get a bunch of succinylcholine that didn't work. So I think it was IM succinylcholine, but that's okay. It was a tough case. They did a good job. They ended up coming in with the guy who was on the verge of getting intubated, a severe asthmatic. And these asthmatics, when they're severe, they are very difficult to manage. And they do very poorly, right? So it's different than your COPDer who like, hey, you feel like you're fatiguing on BiPAP or CPAP. Have you ever been intubated before? Yeah. If you're fatiguing, we can intubate. They're hard to get off the ventilator, but the asthmatics, the young asthmatic that is failing and now respiratory failure to the point of intubation is a very high mortality event, okay? Very high mortality event. So, what are we listening for? I think it's important to understand when we listen to lung sounds, which probably, how many of you routinely listen to lung sounds? Nobody raise your hand because I know you're all a bunch of liars. Nobody routinely listens to lung sounds. You should routinely listen to. Who routinely has a stethoscope that they use? More than 50% of the time. All right. Everybody should be using it. I mean, that's like it's like going up to bat and forgetting you had the damn bat, right? Or the pitcher goes to the mound, and he's like, I don't ever bring the ball with me, so what are we going to do? Okay? You cannot not use that tool. If you don't have a stethoscope, get a stethoscope. If you don't have one in your kit, we got to do something about it, right? You have got to start incorporating lung sounds into your exam, okay? You should be putting a stethoscope on everybody. I put a stethoscope on every patient, almost, right? I'll say 90%. And some of it, I'll be honest with you, is not because I need to listen to their lung sounds. But some of it is because the expectation of a medical practitioner is that this person listens to the most critical of organs, my heart and my lungs. And if they don't even listen to my heart and my lungs, they probably don't give a shit about me, right? So some of this is when I show up and you are a patient and I'm your provider, I am going to listen and pay attention to your most vital of organs, okay? So listen to the heart, and I listen to the lungs. And sometimes I hear stuff, and I'm like, oh, shit, I wasn't expecting to hear that. In every pulmonary patient, every respiratory distress patient, every chest pain patient, you should be listening to heart and lungs, okay? Everyone. Every trauma patient, you should be listening to lungs, okay? It is, you guys are under-listening. I don't even know if this is a word. Like, I'll put money on it that we're not listening to lungs enough, okay? And part of the reason is the same thing with heart sounds, right? You don't always have to know what abnormal is specifically. You just have to know that it's not normal, okay? And that'll be the cue for you. So you don't know what's normal until you listen to enough. And then you're like, ooh, that's not normal, okay? I'm going to pay a little bit more close attention. Oh, it's just not normal down in that one spot, okay? So just a brief overview of lung sounds and where they come from, right? So if you've got hair that is close to your ears, okay, then take pinch a little bit of hair, okay, and roll it between your fingertips and be real quiet and listen, okay? And it makes that little crackly sound, right? That's what rales sound like, okay? Pneumonia, pulmonary edema. Yeah.
I'll throw out one more thing that I would caution all of you to not rely on somebody else's exam.
Yeah.
One, they might not have done it, but said they listened. And two, they might not have experience in listening to abnormal. So listen again.
And the exam changes. It's a dynamic exam. It changes, okay? Almost like a neuro exam, right? It's a dynamic exam on a lot of folks, and you need to be able to follow that. So generally what that sound is and when you hear it in the respiratory cycle as end expiration, or I'm sorry, end inspiration. So at the end of my inspiratory cycle, that's when I start to hear it. So the last third, generally, the last third of that inspiratory phase is where I hear that. And what it is I take all these kind of fluid-filled, boggy alveoli, and they're popping open, okay? You're bringing that air, and they've got a little bit of surface tension because they're moist, so they want to stick together a little bit, and then you're hearing them go, okay? That's what's happening. And it's at the end of inspiration. So when you breathe in, and so I'll listen to people's lungs, and really vast majority of the time when I'm listening for pneumonia, I'm only listening to the inspiratory phase, right? So I go, breathe in, and then I move it, and they breathe out, and I breathe in again. And they're probably like, this guy's not even listening to my lungs. I am, but I'm interested in that inspiratory phase, okay? Now, bad pulmonary edema where they're just wet, you're going to hear it the whole time, right? But pneumonia, CHF exacerbations that are subtle, you're going to hear that at end expiration because I'm taking these moist little alveoli and I'm popping them open, okay? Rales. Like Rice Krispies. Take your hair, roll your hair in your ears, right? That's that little fine crackly sound, okay? Wheezing is exactly what this guy's doing, right? Like straining on the toilet. I'm trying to get that air across and through there. And so just like any instrument, If I change the caliber and I put velocity across there, I can make a sound, right? A bagpipe makes a sound, a pan flute makes a sound, a trumpet makes a sound, lungs make a sound. When I got tight airways and I'm breathing out against tight airways, I wheeze. And it's that musical tone on expiration, okay? So I breathe in fine and I breathe out, right? It's that kind of musical tone, right? I can't wheeze, but you know what it sounds like, okay? It's an expiratory phenomenon, and it's a musical tone, and it's related to air not moving. Now, we'll talk a little bit about silent lungs here in just a second. Now, rhonchi, which is just that kind of junky, loud, when people, you can hear it sometimes while they're talking and breathing. You can hear that kind of large, crackly, big, large airway sounds of wet, kind of mucusy, junky. That's rhonchi, okay? And that's typically going to be secretions, large airway secretions, okay? And you're essentially pushing air past big bubbles or making kind of rattly sounds of pushing air past pieces of mucus and junk, okay? So middle airway sounds can be inspiratory and expiratory, okay? So alveoli is rails, generally inspiratory. Wheezing is small and medium-sized airways, and it's usually expiratory. And then rhonchi is large airway secretions, can be inspiratory or expiratory, okay? So listen to the goddamn lungs, okay? Gosh darn, sorry, Mom. Okay, what about when you don't hear anything, okay? And I worry about this with the asthmatic, the COPD. This is a phenomenon that I see in obstructive lung disease, right? And we'll go back to that instrument analogy. I can have a beautiful trumpet, right? And there's potential to make a sound out of that trumpet, just like there's potential to make a sound out of a wheeze, right? Or out of lungs. But if I'm not blowing air hard enough into that trumpet, I'm not going to make any noise, right? It requires velocity to make a wheeze. If I have such bad disease that I can't drive with any force across that tight airway, I will not make any sounds, okay? That is dangerous, okay? That is deadly. Almost the most dangerous silence. There's only one more silence that's more dangerous, okay? But when you don't hear that, and we'll go back to that inspiratory-expiratory ratio, okay? I don't hear it. I'm concerned. Deep breath in, long expiratory phase. And so what I'll do is I'll add velocity to that, okay? And I'll say, listen, I need you to blow out that breath as hard as you can. And now you'll uncover a wheeze, right? Or you'll listen to them, blow as hard as you can, and they start wheezing. Or when they cough, you'll hear the wheeze when they cough, okay? Because now I'm adding some extra velocity, and it'll pull that wheeze out and make it more audible, okay? Or the really bad COPD patient or asthmatic where you actually give them bronchodilators and they sound worse, right? Where they didn't have a whole, they just a little bit of a subtle wheeze. They could barely hear it. And then I gave them the albuterol. Now they're wheezing everywhere. That's improvement, right? They're actually moving air now with enough velocity that they can generate. Keep doing it. Keep giving them the albuterol, okay? They're not getting worse. They're getting better, okay? That's what we just talked about. Let's take a break, quick break. 5 minutes. that I have to correct myself because I was wrong with the altitude, what I said about altitude stuff. So technically, you still have 21% oxygen at high altitude, but you have a lower pressure, so there's less available gas. So although you're 21%, you have less oxygen molecules available to you because there's less gas overall at lower pressures. So you effectively have less oxygen consumption, therefore less utilization, right? So it's still 21%, but since it's a lower pressure, there's less gas available. So, right, partial pressure. So if I have 100 molecules at sea level, 21 of those are going to be oxygen. If I have 10 molecules at 16,000 feet, then 2 oxygen molecules are available, okay? Does that make sense? So that's the difference. So it's still a 21%, but it's a partial pressure difference. So, is it? One of those guys. Anywho, thanks, Steve, for making me not look like an idiot now when someone goes back and reads this. They'll be like, that guy was full of shit.
What happens on the other end of that, like with divers?
Right, so, yeah, so that's how you get the bends, right? Is you go, if I increase the pressure, then I can saturate more gas into the air, right? So I can dissolve more gas into the air. And then I have more oxygen available for hyperbarics, right? That's the whole concept behind hyperbarics. There's more available oxygen because I increase the pressure. But what will happen is that you'll take nitrogen and dissolve more nitrogen in your bloodstream at low pressure. And then when you come out, the gas essentially comes out of solute and becomes an air bubble, a nitrogen bubble. And that's what the bends is it's undissolved nitrogen at sea level. Where it was dissolving under pressure, it's now coming out of solute and forming gas bubbles. And those gas bubbles can cause all kinds of complications, stroke, heart attack, joint pain, muscle aches, all kinds of stuff. Little nitrogen emboli, essentially. That's what the bends is. Okay, all right. So, obstructive lung disease management. We're going to address bronchial inflammation. We do that with steroids. Okay, we can give it through meter dose inhalers. We can give it as oral steroids like prednisone. I can tell you almost every asthmatic that I send home goes home with 5 days of prednisone. Big dose, 60 milligrams, 5 days. Okay, I don't taper it. I give them 5 days. They go home on prednisone. Okay. And then one of the things that I ask them is, when's the last time you were on steroids for your asthma? It gives me a sense of how many times they have severe exacerbations that require oral steroid therapy, okay? So we give them steroids. They get anticholinergics that help with inflammation and decrease mucus production, right? There's also these, like ipratropium also has a vasodilatory component we'll talk about, and then avoidance of triggers so that I don't create the inflammation by preventative measures too, right? I know prevention is lousy for the pharmaceutical industry, but it does work. Bronchoconstriction, beta agonists, right? So remember fight or flight, albuterol, epinephrine, terbutaline. These are different types of beta agonism, and some are selective, some are non-selective. IV magnesium, mast cell stabilizers, which we don't use in the pre-hospital setting. Leukotriene antagonists. So have you ever had an asthmatic say, I just need, give me a cup of coffee? You ever had that happen before? They're like, I try and drink coffee when I have bad asthma. It has to do with the caffeine, and sometimes we'll give IV theophylline. It can be a bronchodilator. Albuterol, this is kind of our go-to, right? So it's a selective beta-2 agonist. And it gives me bronchial smooth muscle relaxation, and it's nebulized for that direct pulmonary effect, right? We do it in 2.5 milligram SVN with 6 liters, and you can repeat it, right? You repeat it every 5 minutes or so. The dose is the same, peds and adults, okay? Magnesium, this is neuromuscular. There's thought to be two types of effect. One is neuromuscular blockade at the acetylcholine receptor, which inhibits calcium uptake, resulting in smooth muscle relaxation. Don't worry, you don't need to memorize that. And then it also has some decrease in acetylcholine release at the neuromuscular junction. So it inhibits, it's the same reason it's a tocolytic. We use it for interrupting pregnancy or slowing down labor. You can give people magnesium, okay? Because it is a smooth muscle relaxer. And some people actually use it as an over-the-counter muscle relaxer. So they'll take oral magnesium that you get from the drug or from the grocery store, and you can use it as a muscle relaxer, magnesium. It's IV administration. It can cause hypotension because of the vasodilatory effect. They have in the hospital, I can only give a gram over an hour, and it drives me freaking crazy because it doesn't need to be given that slow, but there's a precaution to how fast you administer it. So you want to deliver it slowly. I don't think an hour is reasonable, but I think it's 15 minutes for us. Go ahead. There's mixed results. So there are some studies that say it's beneficial, but it's mixed results. There's not a huge predominance of literature that says, absolutely, this is great. But my thought is if shit's hitting the fan and I got someone who's crumping, then there's not a whole lot of great evidence for epi, lidocaine, amiodarone, and shit like that in cardiac arrest, but we're giving that willy-nilly, right? So that's kind of my thought, right? So, I mean, there's no real good studies to support it. I mean, it's a problem with academics, right? I mean, sometimes it's just whatever. I won't say it. This still requires consult with medical control. I like the way you worded that. I'm coming in with an asthmatic. I gave him albuterol. We're about to give him magnesium. We'll be there in 5 minutes, right? In other words, okay, sounds good. That's you're good. Because they don't know our protocols, right? They don't know our protocols. Culver and I know the protocol. Travis Dirks knows the protocol. A few of the other guys know the protocol. But most of them don't know what you guys can and cannot do. So you could probably get away with a lot of shit, right? Okay?
If you sound like you know what you're talking about.
Right. And you could make a lot of bad mistakes, too, with that, right? So it behooves you to know the protocol. In these ones where you need to call in, it depends on how you phrase it. And docs are notoriously kind of control freaks, right? We like to be the ones calling the shots, right? I want to be in charge. And even though it's a good suggestion, it's not my suggestion, right? So the secret in medicine is what? Get people to do what you want and make them think it's their idea, okay? That's the secret to medicine, okay? Getting people to do what you want and making them think it's their idea, okay? So when you word it the right way, but make sure you're right, okay? That's secret for marriage, too? Yeah. I think it's an overall good secret.
Is there a reason on the respiratory wide mag is a little more stringent, like the 2 grams versus the 50 times hemoglobin?
Yeah, because we know that it's good in eclampsia, and it's necessary, and it's got to be big doses. And we're not so sure it makes a huge effect here, and it could potentially cause hypotension, is essentially what it is. So, hey, just so you know, right, when we give mag, what's our target for eclampsia? How do you know when you got too much mag on board or you're approaching too much magnesium? Physical exam finding. What are you looking for? Yeah. How do you know when you're like, all right, we maxed out on our magnesium? Nope. Loss of deep tendon reflexes. Okay? It's a smooth muscle relaxer, right? It blocks neuromuscular communication. So when I start to lose my deep tendon reflexes, which are involuntary motor movements, right? Then I know that I'm approaching mag toxicity. And we're going to take people in eclampsia right up to mag toxic in a lot of cases, okay? Right up to that point, and then we're going to stop, okay? So big doses. Yeah?
Is there a problem with just bringing the 1 to 2 grams back?
No, I don't have a problem with that. Probably easier to deliver over a slow period of time. So we do it in the hospital. We get mag. It comes in a bag. I sit there and I think I could have discharged you like 45 minutes ago, but I got to wait for the shit to go in, right? So, yeah, that's fine. We're not using mag in pediatric asthma. Doesn't mean you can't call medical control and talk to the peds ED docs. It's just they don't want this. They did not support the overall inclusive nature of magnesium for severe asthma, okay? They also don't have IM epinephrine for pediatric asthma, okay? It doesn't mean that that's not something that could be utilized. It just means that if that's what you want to do with peds, you need to call the peds ER and you need to say, here's what we would like to do. We're giving albuterol. This patient looks sick and crumping. I want to give IV or IM epi, and I want to give mag. We'll be there in 5 minutes, okay? It's not off the table. It just needs to be discussed, okay? That makes sense? We have a lot of restrictions on peds locally. And a lot of that is because we sent all of our peds protocols to the peds ICU critical care folks and said, would you look at all these? And they went through and they said, we would be okay with this, this, and this. We're not so okay with this. So we're pretty light on peds interventions. It doesn't mean that those interventions are not possible. It just, you need to get the blessing from whoever you're going to deliver that patient to, okay? Make sense? Ipratropium, it's a muscarinic antagonist. Remember our parasympathetic nervous system? Muscarinic, nicotinic stuff, right? So muscarinics decrease mucus production, bronchodilation. This is an acetylcholine receptor antagonist. We give 500 mics co-administered with albuterol as a duoneb, right? And I give this one time. So I give a duoneb as my first dose generally, and then my subsequent nebulizer treatments are going to be albuterols, okay? So a duoneb to begin with, or a mix of albuterol with ipratropium, and then subsequent to that is albuterol, 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 okay? Dose the same for peds and adults, again, a single administration. Epinephrine, non-selective sympathomimetic, IM administration. It's just like we do with anaphylaxis, right? We give up to 0.3 Q5 as needed, and it's IM. Where do we give it? Big muscle groups, right? Okay. It's not indicated for severe COPD. Why is that? Who gets really bad COPD? We talked about this. Who gets COPD? What else do smokers have? They got shitty hearts, and they got shitty lungs, and they got shitty everything because they smoke, right? So whoever smokes, quit smoking, okay? So what happens when I give a big myocardial oxygen-consuming drug or stimulus to someone with bad heart disease who's already probably underperfused? You can induce cardiac ischemia and arrhythmias in these folks, okay? Infarct. Okay? So, bad. You can precipitate heart attack type stuff in people with shitty hearts, okay? So, also we don't use it in pediatric asthma. Doesn't mean you can't call it. Now, that being said, if my respiratory failure or if my respiratory distress progresses to respiratory failure and PEA, right? Hydrogen ion acidosis is respiratory acidosis. That H ion is a cause for PEA. Hypoxia is another H that is a cause for PEA, right? If they progress to PEA, now your PEA algorithm, and you're given epi, okay? Does it make sense? Okay? So if you want to give it, just wait. Just kidding.
Nebulizing. albuterol and such, we were giving epi to pediatric patients, we were giving them to adults for asthma.
I don't have a good answer. All I know is that there was some reluctance for the unregulated use of IM epinephrine in asthma. It's still indicated for anaphylaxis, but it is not, after discussion with our peds critical care folks, they don't want it given indiscriminately in severe asthma.
In adults, it's because it's non-selective, but peds, I don't know.
I don't have a good answer for that. I would have a low, if I had a bad asthmatic that's a peds patient, I personally would have a very low threshold to call in and say, I think this person needs IM epi. I have it drawn up, I'd like to give it, I want to discuss it with you before we show up. If they're bad asthma, right?
Before I drop that tube, I try it.
Okay, so, yeah, go ahead.
Where does racemic epi play into all that?
Racemic epi doesn't play into this. Racemic epi is stridor, upper airway. That's a fourth lung sound we didn't talk about because it's really up here, right? And all that's doing is causing direct vasoconstriction, immediate vasoconstriction of that edematous tissue, right? So you do racemic epi to cause vasodilation, vasoconstriction, and reduce the edema of that spot. The problem is once I give it, they're going to sound better. I have to actually watch that patient for like 2 hours plus to make sure that they don't have rebound afterwards, okay? So the short term for your croup patient is racemic epinephrine, followed by steroids, which are a long-term anti-inflammatory, but my immediate anti-inflammatory is the vasoconstrictive effect of epinephrine, okay? Topically, essentially, it becomes topical epinephrine, okay? Okay, so that's our primary pulmonary respiratory emergency, okay? We also have primary cardiac, essentially, respiratory emergencies, pulmonary edema, okay? So cardiac disease with the pulmonary complications, it's generally a transidate. So I have high pressures, high capillary pressures, right? And so I push the water component of blood and plasma into the alveoli, okay? And I end up with a transidate. It's excessive pressure causes that fluid to leak out. It's a thin fluid. I can fix that by increasing the pressure inside the alveoli and pushing it back over if I need to, or by reducing the pressure, and then it will gradually make its way over on its own, okay? Typically, this is a manifestation of congestive heart failure. So we talked about the picture of a dam, right? I dam something up, I get a reservoir behind it, and I'm going to back up fluid everywhere behind that dam, right? So if my dam is in the left ventricle, I got lousy output, but I keep getting blood returning from the right side of the heart, which is functional, well, it's going to back up, and I'm going to end up with high right atrial or left atrial pressures, high left pulmonary vein pressures, and ultimately high pulmonary capillary bed pressures, and I'm going to leak that fluid across that membrane that's designed to be semi-permeable, right? So I leak that fluid across. If I have bad CHF for long enough, well, then I'm going to back that fluid up into my right side, and a lot of times left-sided heart failure ends up with right-sided heart failure, and then that's why you see people with jugular venous distension, puffy legs, fluid overload, right? Okay? There's some other kind of kidney involvement in that too, but we're not going to get into that. So this can be acute or chronic. Chronic congestive heart failure typically is somebody who's compensated heart failure. They got lousy output. We regulate them with diuretics, right? We keep extra fluid off. We say don't drink too much water and don't eat a lot of salt, okay? Right? Because water follows salt. So if I have lots of salt, I'm going to hold on to more water, okay? So the vast majority of these time, these are people who decompensate usually from dietary indiscretion or medical noncompliance, okay? And it's an acute on chronic condition, okay? So they know they have CHF, they still drink beer and eat peanuts, and now they're in a decompensated heart failure, okay? I can also get this with hypertensive emergencies. And hypertensive emergency is severe hypertension with end organ complication. Hypertensive crisis is a blood pressure like 180, greater than 180 systolic over 110 systolic, I think. But as soon as I get end organ dysfunction, then it becomes hypertensive emergency. And pulmonary edema is end organ dysfunction. It's end pulmonary dysfunction, okay? So volume overload, this is typically my decompensated congestive heart failure patient, usually dietary indiscretion, medication noncompliance. You can see all this. This should be nice and kind of gray looking, right? But I get all these kind of cotton ball looking appearances, lose some of these nice demarcations that should be present. They kind of get a little bit foggy there. That's pulmonary edema. It's bilateral, right? If I had this just in this section right here but nowhere else, that's focal. That's a pneumonia, right? This is a bilateral process. It's a systemic process, okay? End-stage renal disease. This will give me volume overload because I don't have a way to get rid of volume until I plug in for dialysis, right? Most of these people pee like once a day, maybe once every other day. Some of them are so bad they don't even pee anymore at all, right? So I don't have an opportunity to regulate. I can't get rid of fluids. The only way I get rid of volume is to go to dialysis. So if I don't show up to dialysis 3 days a week, I hold on to volume. What happens when I hold on to volume? I start to leak that stuff out. Where do I leak it out? I leak it out everywhere. I leak it out in my belly. I leak it out in my legs. I leak it out in my lungs. And I end up with pulmonary edema. A lot of times these people will be very hypertensive also, okay? Hypertensive emergency greater than 180 over 110, end organ dysfunction. This can be, end organ can be acute pulmonary edema, flash pulmonary edema. It can be hypertensive encephalopathy. It can be aortic dissection. It can be renal failure. It can be any sort of end organ dysfunction, okay? Angina, infarct, yeah, absolutely. So how do we manage pulmonary edema? Our immediate effect is to drop preload, right? If my problem is I got too much fluid coming in on the heart and I can't manage it, well then I got to get that fluid and I got to redistribute it other places so it's not hitting the right side of my heart. So I do preload reduction, okay? I can do preload reduction very quickly with nitrates because I get a big vasodilatory effect, right? So I take that reservoir, and if I'm backing up into the tributaries, I've got too much fluid that's backing up into places I don't want it, I'm flooding the banks, well, I just make a bigger reservoir, right? And then that water level drops back down because I made bigger volume. So I create a bigger volume, a bigger venous pool, and I can reduce that pressure, yeah.
Fluid overload. Would you say anatomically the first place that fluid's going to overload is into the lungs, or is it just by case by case?
It depends on where your failure is at. Where's your obstruction? Where is your flow limiting obstruction, right? In congestive heart failure, typically it's the left ventricle. So it's whatever is behind that. People who have left and right heart failure, you'll see both, right? So it'll be in the liver. One of the places that you'll see, if you don't see jugular venous distension on somebody, but you want to know whether or not they're volume overloaded, well, the liver's a big sponge. It sits right behind the right heart, right? It takes all of that fluid from the gut, it dumps it in right at the inferior vena cava before I hit my right heart. It's like a big sponge. So I don't see jugular venous distension, I push on the liver. And I push what volume is in the liver out, and they go, ah, right? And their jugular vein goes, boop. Okay? It's called jugular venous, or it's called the hepatojugular reflux. Okay? hepatojugular reflux. So I'll see that on right heart failure by pushing on the liver because it is the biggest organ right behind that failure, okay? So it depends on what it is, what you're looking at, okay? And then non-invasive positive pressure ventilation, right? Why does non-invasive positive pressure ventilation help me? That's why we spent so much time talking about respiratory physiology in the very beginning. I am now moving away from a vacuum where I suck blood in and suck air in. Remember, when I breathe in, it's not just air that's coming into my thoracic cage, right? When I go and I create a vacuum, I have a superior vena cava and an inferior vena cava, right? And they want to put stuff in my thoracic cage also. They want to put blood. They want to return blood to my thoracic cage so they can get it into my heart. So by increasing the pressure using non-invasive positive pressure ventilation, I'm now giving 5 millimeters of mercury or 5 centimeters of water of resistance to returning blood flow. Got it? So I create a reduction in preload by creating increased thoracic pressure and a bigger venous pool to collect that volume, okay? And you do the two of those together and it's dramatic, right? You take somebody, you're like, I was going to tube you 15 minutes ago. I was like this, getting all my shit together. I turn around, you look great. You look way better. You'll turn people around, and you call the ICU and the guy comes down, he's like, I'm not putting this guy in the ICU. Oh, you were just here 20 minutes ago, right? You would have said, how come he's not intubated already? Okay? So it is a phenomenal way to manage flash pulmonary edema and bad decompensated CHF. The only problem is that you're going to get less tubes because of it, okay? So you'll also get with big nitrate, big volume nitrates, you'll get some afterload reduction also. There's better afterload reducers, but you will get some, okay, in higher concentrations. And then for delayed, so that's immediate. Delayed is, well, I've got to get this off you, so how am I going to do it? Most of the time, I'm going to have you pee it off, right? That's how I get rid of water, is I pee, right? So I'm going to make your kidneys pee off that extra volume. So we're going to give you big doses of Lasix. We used to give Lasix in the pre-hospital setting, but the truth of the matter is it doesn't have as immediate effect, and not every pulmonary edema patient is a volume overload patient, right? So some pulmonary edema is not because they have overwhelming amount of volume on board. It's related to other problems, other crises, okay? But diuresis, and if I can't pee, well, you'll get dialysis, okay? What about in our cardiogenic shock patient, right? Most of these people, I'm giving them nitrates and positive pressure ventilation, both of which will drop your blood pressure, right? So if you come in hypertensive crisis or hypertensive emergency and your blood pressure is 200 over 110 and you're wet, well, hell, I'm going to give you nitrates with no caution, right? Nitrates, 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 BiPAP, okay, or CPAP, okay? What if your blood pressure's 100 over 60 and you are wet? Bad decompensated heart failure. How do I manage you in that circumstance? If I put you on BiPAP, I'm going to make you hypotensive. If I give you nitrates, I'm going to make you even more hypotensive, right? So this is people with severe pump failure, right? They have pump failure. They have severe heart failure. This is generally my patients who are chronic, have severe cardiomyopathy where their ejection fraction is like 15%. They're waiting for a heart transplant, right? Their CHF is so bad that they are like they're well known to the advanced heart failure clinic, and you're calling the special cardiac team because most cardiologists are like, this guy's like end-stage heart disease, right? So the problem is it doesn't take a whole lot to tip them. If I'm only squeezing this much, how much pressure do you think I can generate? I'm always hypotensive. My pressure's always low, right? Now you make me stress out a little bit and I fail, right? Well, I can't try and preload reduce this person, otherwise they're going to be PEA before your eyes, right? So in this group of people, we have to initiate inotropic support, okay? And we do that with dopamine. And 5 to 10 mics per kilo per minute selects for beta activity. So I'll get more squeeze, right? I'll get better squeeze, okay? The problem is people with this bad of heart failure tend to do very, very, very poorly. If I'm putting bad heart failure on a pressor, that's bad news. You guys ever seen anybody with a milrinone infusion? Bad heart failure patients, you transport them, they have their little infusion of milrinone, they wear it. That is a almost pure inotrope. And it's got to be running all the time. Otherwise, they can't generate pressures to perfuse, okay? So that's bad heart failure. We can also get this in the acute setting. Really bad infarct, right? You take out a left main, you take out a proximal LAD, and you lose a whole territory of that left ventricle that no longer participates in squeeze, right? That's bad acute heart failure, okay? Sometimes those people need inotropic support. Mitral valve failure, so you know how you've got, if I necrose, if I have an infarct of those papillary muscles, and they're tethered, right? And it keeps those little valves from prolapsing. Well, if I rupture one of those valves, well, then I just lost that flow. So every time I squeeze some out in the aorta, but I also eject blood back into the left atrium. And so when I'm squeezing both directions, well, guess what happens? Now I'm pushing blood back into the lungs as well as out into the atrium, okay? Or out in the aorta. So they'll end up with bad flash pulmonary edema also, okay? Very difficult population of patients to manage. But this is where we use dopamine for heart failure, okay? It's in our hypotensive, profoundly hypotensive patients with severe heart failure, okay? What about CPAP? So it is non-invasive positive pressure ventilation. We use it in severe respiratory distress or hypoxia in the setting of any of the following: COPD, pulmonary edema, asthma, and pneumonia, okay? I don't like this at all. I don't think pneumonia should even be there, okay? Because what is it about pushing fluid across a membrane that makes non-invasive positive pressure ventilation work? It has to be a transudate. It has to be a thin fluid that I can displace across a membrane, right? Can I displace pus across a membrane? I can't, right? It's not going anywhere. It's still going to be stuck there, okay? Where I will get benefit in this population is think about your really bad pneumonia patients. How do they breathe? Rapid and shallow. So what about their total lung volume are they actually utilizing? Their tidal volumes are small, right? They're shunting. I want to recruit as much functional lung tissue as I possibly can. What is non-functional lung tissue that's not being ventilated well called? Atelectasis, right? Atelectasis. It's air cells that are not being ventilated. Most of us have a large volume of atelectasis that we could recruit to improve our oxygenation, right? Why do we use non-invasive positive pressure ventilation in our OSI protocol? I can't get you to achieve 94% after 3 minutes of tidal volume breathing or 8 vital capacity breaths. We put on non-invasive positive pressure ventilation because there's more lung tissue in there to utilize, and I'm going to utilize it. I'm going to utilize it to maximize this denitrogenation effect, right? This pre-oxygenation, okay? So the benefit is not in the site of where I have pneumonia. The benefit is that I'm going to better utilize what other lung tissue is available, okay? So I think we should take pneumonia off the list, right? I argued this passionately at the last EMS council meeting, and I was shot down. So I said, I'm going to teach it like this anyways, even if you don't change the protocol. So I did not win, but I won. So I think we need to, when you think about this, think about it this way. COPD makes sense, right? Pulmonary edema makes sense. Asthma makes sense. Atelectasis makes sense. Pre-oxygenation makes sense. Look at that. CPAP. So what happened here is you're like, oh, shit, okay, well, I need another lung disease that starts with a P, so pneumonia, right? Okay, that's what I think happened. I can't prove it. So think about it this way, okay? The protocol won't change, but the way you think will.
So what was their argument? Why did you get shut down?
I don't know. But when you go back and you look at it, even look, the C in COPD is bold and capitalized, right? The A in asthma, the P in pulmonary edema, and then it's a small p in pneumonia. So it doesn't even, it knows it doesn't even belong in there. I tried that argument too, and that didn't work either. So what are our contraindications for CPAP? Well, respiratory arrest, right? Unconsciousness, vomiting, and facial trauma with deformity. All these fall under kind of this airway protection. People have to be able to protect, self-rescue, right? Think about who we put, who is the greatest population of people that get CPAP on a day-to-day basis? Every day. They're not even sick. Sleep apnea, right? I put it on and I go to bed, right? I'm out. I put it on, I go to bed, okay? Most people don't puke themselves unless they're wasted the night before in the middle of their sleep. You get nauseous, you wake up, you can self-rescue, right? But you don't have to be alert and oriented times 3 and GCS of 15, right? We put people on it and we say, go to bed, okay? And they usually sleep great because they slept so shitty beforehand because they got obstructive sleep apnea. Now they're like deep sleep and their body's like, oh my God, this is the sleep I craved, right? But they have to be able to self-rescue, okay? Now when we do pre-oxygenation, this is somebody who I have said, I'm going to intubate you already, okay? I'm intubating you. I'm already committed, right? You're getting intubated. And I'm going to put you on CPAP to maximally pre-oxygenate. That means someone needs to be assigned to that person to self-rescue or to rescue for them, right? So you don't necessarily strap on the thing and turn away from them and get all your shit together. You've got somebody who's there using that device who can be their rescuer if they need it, okay? It is a temporizing measure to achieve pre-oxygenation. They don't have to be alert and oriented times 3 with a GCS of 15. They can be failing. Many of them will be, okay? But you need to have somebody there who is addressing that airway, utilizing that positive pressure ventilation to achieve adequate pre-oxygenation before we are going to put them at risk for severe apnea, right? With intubation, okay? Make sense? Nowhere in our protocol does it say that you can't use it on people who are altered, okay? It is people who are unresponsive, unconscious, okay? People can be altered and still benefit from it as long as they are not at risk for aspiration, okay? Preload reduction, right? So hypovolemic shock, acute coronary syndrome with cardiogenic shock. Preload, remember, I'm going to change negative pressure ventilation to positive pressure ventilation. I'm going to change not only how I ventilate, I'm going to change hemodynamics. I do this when I intubate people. I do it when I put them on non-invasive positive pressure ventilation. So some of these folks, if you really want to put somebody on it, maybe you got to pre-treat them with a liter of fluid, right? Get their volume up because you're about to volume reduce them technically, right? Or you're about to preload distribute them, okay?
Bag valve mask respiration as well.
Anything where I'm blowing pressure in. That's why hyperventilation kills in our resuscitation efforts, right? I'm doing my damnedest to get good perfusion with excellent compressions. Meanwhile, I got somebody up at the top bagging and working against me. Might as well be pushing you off the chest, right? Bag, 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 bag. I'm going to screw you out of good compressions. That's what they're doing, right? So low pressure, low volume, slow ventilations, okay? You got someone at the head of the bed who's compromising your ability to get good compressions, right? That's why we de-emphasized ventilation in cardiac arrest, because I cause a reduction in preload, okay? And then anybody where I'm going to increase the possible risk of trauma-related illness, increased intrathoracic pressure. So remember that potential space. If I got a simple pneumo, it might become a tension pneumo, okay? When I start blowing air in there, I could make things worse, okay? So we don't like to use it in trauma patients in general because, one, most trauma patients in shock are hypovolemic shock, and trauma patients generally have a high incidence of mechanical chest disease, right? So we start with pressure with PEEP at 5. We increase to 7.5 after 15 minutes. Discontinue if their mental status declines significantly. They drop their pressure less than 90, or they have worsening hypoxia or severe respiratory failure. With severe asthma, because of trapping, you may want to consider lower than 5. I don't know if you can even achieve that with our setups, but if you can reduce it to even less, because really asthmatics, where they benefit, it's not as much stenting, is that they have such respiratory fatigue when they at end stage that they just kind of need a little bit of inspiratory help, okay? Not so much that you're going to increase air trapping, and you'll hear a lot of people say, don't use CPAP in asthma because of the air trapping, right? But the truth is, these people that are failing in conjunction with bronchodilators, that they do benefit from CPAP, okay? But you have to be cautious for barotrauma. When I intubate these people that fail, you want to use sedation and a paralytic, okay? This is someone who you want to use drug-facilitated intubation, okay? Ketamine is a great agent for asthma. It has a bronchodilator effect. Some people have in their protocols actually that when they put an asthmatic on CPAP, they give them an analgesic dose of ketamine because it really reduces the stress, it reduces the anxiety of being in respiratory distress, and it provides some bronchodilator support. We don't have that in our protocol, but a lot of people advocate for the use of ketamine with severe asthmatics, okay? Even prior to intubation, okay? But when you do decide, I'm going to tube this person, ketamine's probably your best agent.
The other thing with the sedation is the ketamine doesn't provide any respiratory comfort. As far as like a benzo where you can have respiratory depression.
Well, so this dramatic drive to improve their ability to ventilate will drop that. Now, remember when I gave the ketamine lecture, you do have a bit of a negative inotrope effect, a direct inotrope negative effect with ketamine that it's debatable how much it really plays a role, but I would avoid it in our acute MIs and decompensated heart failures, and I would prefer an agent like etomidate as an induction agent, okay? So ketamine is great, but it's not great in everything. Okay? Once you have sedated somebody with lung disease, they need to be ventilated. The only thing that makes it hard to ventilate these people is when they're trying to ventilate and cough and gag and work against you. They need to be out. This is somebody that I don't care about their neuro exam when you show up. Paralyze them and sedate the hell out of them. Okay? Versed, heavy sedation. Fentanyl for analgesia. Once you know you have a tube in place, you can give fentanyl for analgesia, okay? The risk of putting these two together is that we don't call it conscious sedation. We give it for two separate indications in the setting where I've already secured an airway and I'm not at risk for respiratory failure from oversedation. Does that make sense? I don't do this without having a tube on somebody. This is after I've secured and confirmed an airway. I give fentanyl for analgesia. I give Versed for I give Versed for sedation, okay? And then I paralyze them because you can't ventilate these people well unless they're not participating, particularly your asthmatics. And remember, you need to have a low respiratory rate. You can allow for, you don't have to ventilate these people fast to correct their end-tidal CO2. It's going to take a while for that end-tidal CO2 to correct. You don't have to fix it in the 10 minutes that you're transporting. It's going to get fixed over the hours and hours and hours that they're in the ICU. So you can allow them to be hypercapnic. It's more important to not cause barotrauma than it is to fix their pH rapidly. Okay? So slow rate allows for full expiration. Okay? And sometimes I will push on the chest of a bad asthmatic to help get some of that air out. So they breathe out and you can push on their chest and get some more air out. Because you want to eliminate all that air that's trapping. I'm going to push it out before the next breath. The only way to effectively ventilate these people is to do it very, very, very slow. Okay? And be cautious with PEEP, applying PEEP to these folks in too high of pressures once you've intubated them, particularly in asthmatics. Very, very, very difficult to manage. Low and slow is better. Don't worry about fixing their pH rapidly. Okay? Does that make sense? Waveform capnography, I expect everybody to be using waveform capnography and anybody who has respiratory distress. Any respiratory complaint, it's as good as a pulse, blood pressure, SpO2. We should have end-tidal CO2. Okay? There's no excuse. It is standard of care. Respiratory complaints get capnography. Anybody that I have intubated needs to have that in place. Okay? I know it's not foolproof. I know you can get problems with it and the tubing and the connection and the puke and whatever, but I don't want it not utilized because of that. I want it, you can say, I tried and it didn't work. That's fine, right? But I don't want it it just plugs up with shit anyway, so I never use it. No. Use it till it plugs up with shit and then stop using it, okay? But it needs to be part of our assessment, part of our management strategy. Okay, yeah.
PEEP after for an asthma patient get intubated. Careful with PEEP. You just talked about CPAP and asthma though.
Yeah. So it's not so much the end effect. And remember I said in there that if you can use a lower pressure with CPAP in asthmatics, you want to use a lower pressure. It's not that I'm not getting the stenting that I get with emphysema. Right, that's where you really get the benefit with emphysema is I get stenting. And you ever see these little old emphysematous patients? My grandma was a bad smoker. She used to do the same thing. And when they breathe, they do this pursed lip breathing where they go. What are they doing? Right, they're auto peeping. Right, they're stenting their airways open. By blowing out against a closed surface, I can create some back pressure. Right, so that's all that I'm doing with CPAP. Now, I don't get as much of that with asthma. Where I really get the benefit with severe asthma is in that inspiratory, that support for inspiration, because they are so fatigued. By the time they are that bad, they are absolutely fatigued, and it's like they're failing themselves. Their ventilatory muscles are failing. They need that. And if you could just give them that trigger and just that inspiratory support only, and you could do that, it's called IPAP, inspiratory positive airway pressure, just not continuous, that would be ideal. But we can't do that. We don't have that, so you have to be careful with that end expiratory component. Okay? Tracheostomy and stoma management. How many people have dealt with an acute tracheostomy stoma complication? They can be difficult and intimidating because we don't see them frequently, right? It's kind of a novel instrument. So this is a direct communication from the anterior neck into the trachea, right? Here's where we do our crike. Our crike goes in between the thyroid cartilage and the cricoid cartilage. A tracheostomy goes through the trachea. So it's lower than our traditional crike, okay? And it's a long-term airway. So some people will have a laryngectomy where this is removed for cancer reasons and they have no communication from above to below. And other people have abnormalities like laryngomalacia, where it collapses and they can't effectively breathe, or they've been intubated for a long time and they have to be on a chronic vent. You can't manage somebody on a chronic vent this way forever, so they end up getting trached. Okay? You can't walk around with an endotracheal tube, so you end up getting a tracheostomy for chronic ventilator dependence. Okay? Oral tracheal intubation is great for acute ventilator management. And a lot of the patients in the ICU, once they've been there and they're like, look, this guy's going to be here for a month. Let's just trach and peg them, right? So they get a peg tube and they get a tracheostomy because you don't want to be doing this through the mouth the whole time, okay? So that's what it's for. Most of our complications are going to be related to plugging of the stoma, right, or a displaced catheter, okay? Don't forget the basics. Most of these people, minus the laryngectomy patients, can be bag ventilated if they need it. But you have to plug the stoma site to be effective. Otherwise, you're just going to be blowing air out the stoma, right? So if push comes to shove and I have to ventilate, BVM them like anybody else. Back to the basics. Just make sure you cover the spot that needs to be covered, okay? In the case of obstruction, you can remove the inner cannula. So a lot of them, and adults particularly, will have an inner cannula that sits inside here. You can pull that out. That can be suctioned or replaced or cleaned and then put back in. That's usually what gets plugged. Now, peds, it's too small. So they don't have an inner cannula. But you can suction through it, and you would hyperoxygenate somebody beforehand, right? Just like you would any suctioning, and you pass the catheter in and you suction it out, okay? If the catheter is dislodged from the stoma site, then what you want to do is reassemble it, the kit, and a lot of families will have a replacement there also. If they call you, you can get a replacement. You'll have the obturator that sits inside the cannula, provides some integrity to it and shape so that you can pass it in through the stoma into the trachea. And it goes point down, falls in. And then a cuff that gets inflated, okay? Does that make sense? If it's been there for greater than a week, the likelihood of having a false track develop while you try and replace this is minimal. Anything under a week needs to be replaced by a surgical crew, okay? Because what happens is you don't have the connections established yet. The track is not established. And so what you can do is push it in and create a false track, and so you run that catheter right in front of the trachea instead of into the trachea, okay? Consider using a bougie, just like when we do our crikes. Consider using a bougie, right? I can stick a bougie in there, and I can pass a catheter over the bougie and then use that as a direct guide, okay? And a bougie is easier to facilitate. It's smaller diameter. I'm less likely to create a false track, okay? Yeah. This, again, most underutilized tool in emergency pre-hospital care, I think, in my opinion. One thing you may run into, usually within a month of when somebody has a tracheostomy placed, is called a tracheoinnominate artery fistula. I have never seen one of these, but I think I should just touch base on it so that if you see it, you know what it is, okay? Most of you will probably never, ever see it. What happens is you put in a tracheostomy, you inflate the cuff is under too high of pressure, and it creates necrosis and ischemia of the trachea and the soft tissues in between the trachea and the innominate artery that comes off of the aorta, right? And with inflammation and necrosis, you can create a fistula, and you'll have an innominate artery bleeding directly into that trachea. Okay, so if you show up, someone said, I had this trach placed a month ago, and they're bleeding like stink from that site, tracheoinnominate artery fistula till proven others. Most will apparently, I've never seen one, most will have a little sentinel bleed beforehand. So if you get somebody who's had a has a tracheostomy that was placed recently, and they're like, oh yeah, I had a little bit of blood there, but it's gone now, take them in. It needs to be evaluated, okay? Most will have a sentinel bleed. The first step is to overinflate the balloon. So take the cuff and overinflate it and try and tamponade and compress the artery. That's your first step. Most of them will be managed that way. If that fails, then you have to take a finger and stick it inside the stoma and pull it up towards the sternum. And you pinch the innominate artery against the sternum for direct pressure, because there's no other way to get direct pressure. Okay? These people are going to die. Okay? So you sticking your finger in there and messing something up is the least of their concerns. There is a very, very high mortality rate. So if you're in a circumstance where you see this, right? I mean, I hate to say it, but they're going to die. So stick your finger in there, okay? A lot of the times you'll have to intubate them, right? You'll have to intubate them from above. So you intubate them traditionally, and you put a finger in, and you pull forward, and you get down there, and you pinch it, and you hold pressure. And then your tube goes, you'll have to use a smaller tube probably, your tube goes behind the finger. And if you can't get your finger in the trachea, then you go in the soft tissues between the trachea and the sternum, like a false track, and you pinch it off that way. And then you pass a tube through the trachea. Okay? So if you see massive, massive, massive bleeding from a recent tracheostomy site, overinflate the cuff. If that doesn't work, you have to do direct pressure and pull it forward, okay? I hope you never see one. But I figure we should just touch on that for the rare, rare, rare complication. Otherwise, the vast majority of these are going to be you replace it on a well-formed track or you suction it out, okay? No. What are you talking about?
So if there's a blockage, right?
Yeah.
We have to bag them, and it's tube's still in there. There's a balloon, right?
Yeah.
That's covering the trachea. So we have to deflate that for the air from the bag to go actually down to the lungs.
He's talking bag about masks, not bag.
Oh. Yeah. You'd have to. Yeah. Otherwise, you're right. You'll just fill up their gut. I see what you're saying.
You'd have to pull it and block the.
I thought you were talking if you hook up to this
Yeah,
and you
sorry.
bag off of the trachea. It's like,
No.
I see what you're saying. Yeah, you'd have to create an. But most of the time, if you're at a point where you're bagging, that thing's dislodged or plugged to the point where it's coming out, you need to obstruct over it, right? And then you can replace it and then secure it again, okay? Don't forget to use a bougie if you need it. All right, I think that's all I have. Yep. Any questions? Sorry I ran late. I hope I never see it.